Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join this group. It is very good for accessing all lecture related information. You can use the link to join the group. We have a Google Drive where the PDF of all lectures are available and a master integration key with the help of which you can navigate between the Google Drive and the YouTube lectures. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we are in continuation with our uropathology lecture, and the topic of the day is prostate, a tale of hyperplasias, other neoplastic mimics, and preneoplasias. And to talk on this, we have Dr. Mitadru De Sarkar, who is an MBBS from JIPMER, MD from JIPMER. Dr. Sarkar is a consultant histopathologist at the famous Dr. Lal PathLab, Kolkata reference lab. He is also a histopathologist and cytopathologist at Calcutta Heart Clinic and Hospital, and a consultant histopathologist at Wizderm PathLabs, which is a specialty dermatopathology laboratory. Dr. Sarkar has been an ex-assistant professor of the Department of Pathology at the SMV Medical College and Hospital, and an ex-consultant pathologist, SRL Diagnostics and Fortis Hospital, Kolkata. He has authored a book which is called Pathology for Postgraduate, which is available on Amazon. It also has a Kindle version. You can easily access this book and buy the book and read it. It is very good. With this, I would request Dr. Mitadru De Sarkar to start his lecture on prostate, a tale of hyperplasias, other neoplastic mimics, and preneoplasias. Over to you, Dr. Sarkar. Thank you so much.
Hello, and welcome to this discussion on prostatic pathologies, which mostly concerns with the various hyperplasias and the pseudo-neoplastic mimics, and as well as the preneoplasias, that is the prostatic intraepithelial neoplasias. Now, from the PG point of view, this particular chapter might not be very important. You can easily bypass this chapter and still get good marks as far as scoring your slides is concerned. But I believe for those who are routinely reporting prostatic pathologies, this particular chapter is probably one of the most important ones because it helps you avoid making misdiagnoses when you see especially true cut biopsies. We start off with the entity which is benign prostatic hyperplasia. Now that's one of the simplest entities in the book, and we will go through it very briefly with just a basic understanding because that's the commonest pathology that you mostly see, and most of us are very well aware of the nuances that we get to see with this particular entity. Now, if you follow the last discussion that I had conducted, I had talked about the various zones of the prostate, right? We had talked about the central zone, we had talked about the peripheral zone towards the anterolateral aspect of the prostate, and especially in the mid part of the prostate, that is in the region of the verumonotum, we had said that the transitional zone is very well developed. And it is in this particular zone that the benign prostatic hyperplasia pathology arises. So it's basically a hyperplasia of the various glandular elements within that particular region, but it could also involve the stroma. And in some cases, it could be an equal mixture of the glands as well as the stroma, while sometimes the stromal element might be much more predominant. So over here in the right, you see the enlarged hyperplastic nodule of the BPH, which has resulted in the compression of the peripheral zone of the prostate. You also see that this particular region, which is marked out in V, that is in the verumonotum, is towards the posterior aspect of this prostatic hyperplastic nodule. Now, depending upon the type of representation of the element which is present within the hyperplastic nodule, the gross appearance of the prostate might vary. So if you have an epithelial, that is the glandular element predominant histology, the nodules that will be seen on gross examination will not be that well developed. However, if you have a predominance of the stroma, you will get much more well developed nodules, as you see in the second picture. However, in most of the cases, you get to see a good blend of the stroma as well as the glandular elements. And in such cases, there are some places where the nodularity might be much more prominent, which is the stromal component axis. And in some areas where it is vaguely nodular, which is the glandular predominant areas. So with a predominantly non-nodular kind of a gross appearance of the prostate, you know that it's going to be a epithelial predominant one. If there is a very prominent nodularity to the prostate, you know it's going to be stromal prominent, stromal axis. And if there's a vague nodularity in some areas and a proper nodularity in some regions, you know that it's going to be a mixed pattern. However, the ones that we see most often routinely are the ones where you have a sizable element of epithelial hyperplastic elements, and these dilated epithelial hyperplastic elements give rise to what is known as the spongy appearance of the cut section of the prostate. And once you press the prostate, you see the milky secretions come out of the spongy areas. And if you see under the microscope, you see that those hyperplastic glands are very well evident, and you look into the glandular structures, you see that they're very large and they have this very florid, almost papillary kind of elongations of the hyperplastic prostatic acinar element. So there's a pretty much complexity to these glands, which are usually large, and they are thrown into papillary enfoldings. And if you look into these glands at a higher power, of course, you will see the bilayer, the characteristic bilayer, wherein the inner layer is of the acinar cells and the outer layer is of the basal cell layer. As you can see in this particular image, you have these very well demarcated acinar cells with abundant pale vacuolated cytoplasm, while towards the periphery you have this slightly rounded, that is cuboidal to almost flattened kind of cells, which is the basal cell layer. And this is the hallmark of benignancy of the prostatic acini. That is the presence of the bilayer of both the acinar cells and the basal cells. Now, as I had said already, in some areas you might have a glandular predominant histology, while in some areas the overgrowth might be purely stromal, which is known as a stromal hyperplastic nodule. So if you are to get a prostate where there is a over representation of the stromal element, you will not get those glands. Rather, you will get a proliferation of the fibromuscular elements, most often seen in the form of a fibrocellular proliferation around the small blood vessels. But in the later stages, they might also be composed of smooth muscle bundles, which are arranged in fascicles. Now, that was all about the usual benign prostatic hyperplasia, and that's a very simple entity. Most of us will be able to diagnose it straight on. I'm moving on to the slightly more complicated range of entities that we get to see even in routine prostatic pathology. Sometimes they cause confusion, especially on a needle biopsy. So these are the pseudo-neoplastic prostatic pathologies, and here we shall be talking about the miscellaneous uncommon hyperplasias, atrophy, and also the entity known as adenosis. Now, this is basically a part of the chapter where we deal with the various tricky prostatic pathologies. That is, some of us in a tug of war as far as diagnosing the case is concerned might be favoring the benign entities like adenosis or partial atrophy, while some of us are adamant that it's a carcinoma and we'll call it acinar adenocarcinoma. But when you take the case to the most senior experienced pathologist of the group, you might see that he or she comes up with a diagnosis called atypical small acinar proliferation, which is suspicious of adenocarcinoma, but not 100% confirmatory of an adenocarcinoma. And in most of the cases, this particular diagnosis of ASAP would have been given after doing a diligent, thorough immunohistochemical evaluation of the biopsy sample. So in this particular discussion, we shall be talking about these exotic benign entities like adenosis and the various range of atrophies that you get to see. And we shall, towards the end of this discussion, also talk about this rather nebulous constellation of entities which will fall into the zone of ASAP, that is atypical small acinar proliferation. That's basically not a single diagnosis. It just means that we are not confident enough to call it an adenocarcinoma, but at the same time, we also have the thought process of some rather unusual benign entities like adenosis or partial atrophy at the back of our mind when we are giving out that particular diagnosis. Now, when I talk about these various benign mimickers of prostatic adenocarcinoma, keep one thing in mind: you will not see equal incidence of all these entities in the TERP as well as in the needle biopsy specimens. There is going to be a variable proportion of representation of these entities. Thus, for example, in the TERP specimens, that is the transurethral resection of prostate specimens, you are more likely to get entities like adenosis, which was priorly called atypical adenomatous hyperplasia. We don't use that atypical adenomatous hyperplasia term now because it confuses the clinician. We call it adenosis. Basal cell hyperplasia, entities within the prostatic urethra like the nephrogenic adenoma, clear cell cribriform hyperplasia, and sclerosing adenosis. Both in needle biopsies as well as in the TURP specimens, you get an equal incidence of such pseudo-neoplastic entities like atrophy, radiation atypia, as well as the verumonotum mucosal gland hyperplasia. In the case of needle biopsies and usually not in the case of the TURP specimens, you get to see seminal vesicles once a while, and this seminal vesicular tissue might be sometimes confused with the prostatic adenocarcinoma. We had already discussed that issue in the first chapter where we had talked about the prostatic histology. And there are some entities which are unique to the needle biopsies, and you will not get those pseudo-neoplastic entities in the TURP specimens, and these are colonic mucosa and the bulbourethral gland or the Cowper gland. Now coming to adenosis. Now this is probably one of the most important pseudo-neoplastic mimics of prostatic acinar adenocarcinoma. In a TURP specimen, usually you will not have much of a difficulty with this particular entity, because as you see, there's a very well circumscribed pattern of proliferation of almost back-to-back coalescent prostatic acini of varying calibers. You see towards the center of this lesion, you have the smaller prostatic acini, while towards the periphery, you have the large dilated prostatic glands. And when you have a pattern of this heterogeneous kind of mixture of various size glands, and you look within those glands and see that the features within the smaller glands are more or less equal to what you see in the larger glands, you know that this is an adenosis, which is a non-neoplastic entity. The problem arises when you have a true cut biopsy being taken out from the part of this adenotic nodule where you are having a coalescent proliferation of smaller glands, like say, for example, here and here. So in the case of a true cut biopsy, through a nodule of adenosis, you will get to see this compact coalesced kind of prostatic glands, where sometimes the basal layer may not be that well appreciable. But even within this context, you will see that with the smaller glands, there are usually larger glands which have a benign morphology. So that's one clue. And if you look within this prostatic glands, within this focus of adenosis, you will see that in most of the places, you can very well appreciate the bilayer of the acinar cells and the outer layer of the cuboidal cells, which are at some places slightly flattened out. Okay, so this basic bilayered morphology of the acini as well as the basal cells is usually preserved in the case of adenosis. However, at some places, especially because of tangential sections, you might not be able to appreciate the difference. So the most important thing in adenosis is the crowded gland pattern, wherein you have varying sized glands, most often small, but also admixed with larger glands, which is a diagnostic clue. And if you look within these glands, you will see that the cells are showing some amount of nucleomegaly, and at some places you might get a nucleolus which is slightly prominent. These are called micronucleoli, but these are not as scary as the large macronucleoli, that is the cherry red colored large nucleoli that you get in the case of, say, prostatic intraepithelial neoplasia high grade, or in the case of a prostatic acinar carcinoma. However, the problem arises because within some of these glands, you are not very well able to appreciate the basal cell layer, and you might have to take the help of immunohistochemistry to spot those out. But keep in mind that even with IHC, you will sometimes not be able to reach a conclusion as far as a true cut biopsy is concerned. We shall be talking about that subsequently. Like say, for example, we have directly proceeded to the granddad of all of these markers. There is a PIN4 cocktail. There is the triple cocktail. As we have already discussed, the triple cocktail is a combination of three markers. So you have the basal markers like the high molecular weight keratins along with P63 and also MKR. So in a benign gland, you expect the expression of P63 and HMWK, that is a high molecular weight cytokeratin, in varying proportions, but you usually do not expect to see MKR expression. So as you see, and always remember that as far as the expression of the basal cell markers is concerned in prostatic pathology, any expression of even one or two cells shows that the cell has got basal cells and that it's a benign prostatic acini. So if you see using that particular logic, we see that many of these glands are actually benign, wherein there is a variable, but there is expression of these prostatic basal cells, which are basically marked out in brown, that is by the Dept. However, you see that within this particular background, there are some acini which have actually picked up the red color of MKR, and they are not expressing the prostatic basal epithelial markers. Now, these particular glands might raise a false positive suspicion of prostatic carcinoma, but then you will have to go back to your histology slides and see that most of these glands are having rather benign and innocuous nuclear features. So you will not call them carcinoma straight away. Always remember that you should not make a diagnosis of a prostatic acinar carcinoma in a needle biopsy of a prostate just by looking at one or two glands. You will have to take the entire range of glands within a field of view into consideration and then make your decision. So adenosis in a nutshell is that it is basically a circumscribed aggregate of variably sized glands, many of which are small and round, and sometimes might raise the suspicion of a prostatic acinar carcinoma, but always appreciate the fact that these are usually admixed with larger, obviously benign glands. But basal cells might not be well appreciable at places, and that particular issue might not be solved even with immunohistochemistry. Like, for example, in this crowded focus of adenosis, you see on using immunohistochemical marker for, that is the basal cells, that is the high molecular weight keratins like 34 beta E12, you see that although a few of the glands are seen to express the basal marker, there are quite a few glands where you are having no expression. So remember that a few of the adenotic glands within the focus of adenosis might not show expression of the basal markers. So these are the features which are shared in adenosis and cancer. You have a crowding of the glands. You can have crystalloids, which are seen in the case of the prostatic acinar carcinoma. You can have micronucleoli, which can create an issue. You can have ill-formed and scattered glands with some amount of infiltrativeness, like morphology at the periphery. MKR immunoreactivity might be sometimes seen within the glands, and there can be a focal negativity for basal cell markers. Now, coming to sclerosing adenosis, this is another entity which is sometimes seen in the case of a TERP specimens, wherein along with the proliferation of the glands, you also have a proliferation of the stroma, which looks very, very cellular. The hypercellular stroma also has a tendency to form collagenous bands around this proliferated acini, which at some places might look like they do not have a basal cell layer. So again, you will have to utilize immunohistochemistry, and you will see that on utilizing HMWK, that is 34 beta E12 marker, you see that there's a striking positivity for basal cells in all these glands. Another important thing within the context of sclerosing adenosis is that these basal cells usually show some amount of myoepithelial differentiation and start additionally expressing the protein S100. So if you do an S100 immunostain, you will see that quite a few of these basal cells also pick up expression of S100. Now, coming to basal cell hyperplasia, this is another entity which is sometimes seen in the case of the TERP specimens of the prostate and can sometimes lead to a false positive diagnosis of a pattern 4 acinar adenocarcinoma. But I appreciate the fact that although there is a cribriform architecture to this proliferation, the cells are mostly basaloid. That is, they have very large nucleus compared to the volume of the cytoplasm and hyperchromatic looking, almost a basal kind of a morphology. And this is because in the conventional hyperplasias, while you have a hyperplastic element which is mostly involving the acinar epithelial cells, in this hyperplastic process, you have a proliferation of the basal epithelial cells. And of course, you know that ISC will be very helpful, because if you use markers like P63 or HMWK, these basal cells will just light up. There are two types of basal cell hyperplasia. In some cases, you can well appreciate the acinar lumen along with the acinar cells towards the periphery, and you call this incomplete basal cell hyperplasia, while sometimes you have these solid nests of the basalart cells, which are called complete basal cell hyperplasia. Usually you get a mixture of both, of incomplete as well as complete basal cell hyperplasia. And like I said, they sometimes have a cubiform architecture. And in a few cases, these cells might even have a bit of a prominent nucleoli, which is known as atypical basal cell hyperplasia. And that again might give rise to a false positive diagnosis of an adenocarcinoma. So basal cell markers are very, very helpful. Like, for example, in this image towards the left, you see that there is a florid proliferation of these basalart cells, resulting in an incomplete as well as complete basal cell hyperplastic pattern. And when you utilized IHC stain for high molecular weight keratin, 34 beta E12, you see that these basal cells have just lighted up. This is another case where you have a striking proliferation of both incomplete basal cell hyperplasia and a couple of nodules where you also see complete basal cell hyperplasia. And again, utilizing HMWK, you see that there is a strong positivity for these basal cell elements. In this particular case, the immunostain is actually the PIN4 cocktail. So you see that the cells are not expressing MKR, and they are rather expressing diffusely positivity for both P63 as well as the HMWK. As a result of this, there is almost no white appearance to the basal cell layer because both the nucleus has been caught by P63 and the cytoplasm has been picked up by high molecular weight keratins. Now, coming to cribriform clear cell hyperplasia, this is again another cribriform kind of a pattern of proliferation, except that in this particular case, the cells which are present within these cribriform groups have got the acinar morphology with more abundant vacuolated cytoplasm. But because of this, they could be sometimes mistaken for a pattern for acinar adenocarcinoma. But appreciate the fact that towards the periphery of these cribriform elements, you have this layer of cuboidal to slightly flattened looking basal cells. And of course, you could pick up these basal cells with, again, the usual markers that I've talked about, high molecular weight keratin. You could also use P63. And this shows that there is a preserved basal cell element at the periphery, and hence it is not a acinar adenocarcinoma, because acinar adenocarcinoma will not have basal cell expression of any kind. Coming to verumonotum mucosal gland hyperplasia, again, this is a particular pathology which I had talked about in detail in my first lecture, which I had conducted on prostatic histology. This is again a structure which is seen at the level of the mid gland of the of this prostate, and this is basically a crowded proliferation of variably sized glands, many of which are small. As a result, you could again sometimes make a mistaken diagnosis of acinar carcinoma within these glands, but appreciate the fact that a good number of these glands have got these interluminal corpora amylaceae, so that's always a good sign that the glands are probably benign. So you see the corpora amylaceae over here, and if you look closely, you can again appreciate the fact that most of these glands have got the bilayer of both the acinar cells as well as the basal cells towards the periphery. And of course, you can utilize HMWK and P63 to pick up this layer of basal cells. But again, at some places, because of tangential sectioning, this particular difference between the basal cell and the acinar cell layers might not be that well appreciable. Another entity is the hyperplasia of mesonephric remnants, which can actually present in both a lobular or an infiltrative kind of a fashion, and sometimes it has a tendency of being present in the periprostatic tissue, and because of which, again, you might give a false positive diagnosis of a prostatic acinar carcinoma which has infiltrated the periprostatic fat. Now, an interesting thing about these glands is that they're very simple tubular glands, but at the same time, they could also have a slightly complex tubulopapillary morphology. Appreciate the fact that they do not have the slightly abundant vacuolated cytoplasm that you see in the case of a prostatic acini. And some of these glands have a bit of luminal undulations to them, slightly irregular in appearance. And once in a while, they can even look haphazardly infiltrative. And again, eosinophilic secretions within these glands is an important diagnostic clue. And what about IHC? Remember that these glands have got the basal cell layer. So if you utilized high molecular weight keratin, you will see a positivity within these glands. So towards the left of this image, you see the normal prostatic acini, where the basal cell layer is picked up by high molecular weight keratin. Towards the right, you have got these mesonephric elements, hyperplastic mesonephric elements, which are again showing the presence of the basal cell layer on high molecular weight keratin. But if you utilize a marker like, say, prostate-specific antigen or PSMA, you will see that there is an expression of those markers in the prostatic glands, but not in the case of the mesonephric elements. So that's an important diagnostic marker that you can use to identify the hyperplasia of these mesonephric remnants. However, keep in mind that usually this is a histological diagnosis, and most of the times you will not need to take recourse to immunohistochemistry to make this particular diagnosis of hyperplastic mesonephric elements. The presence of those interluminal secretions, along with the bland morphology of the glands and the slightly prominent basal cell layer towards the periphery of these glands, along with the lobular configuration, usually helps in making this diagnosis by H&E itself. The nephrogenic adenoma of the prostatic urethra is a pseudo-neoplastic pathology which can present in the form of a polyp within the prostatic urethra. Within this polypoidal layer, you see that the lining is by a layer of cuboidal cells, and within the stroma, again, you have a proliferation of small tubular glands which are again lined by the cuboidal cells, which show some amount of hobnailed morphology. So the presence of those hobnailed morphology within those tubular glands is an important diagnostic clue within a polypoid structure which is sometimes protruding into the prostatic urethra. You can see the same neoplastic pathology even in the case of the urinary bladder, pseudo-neoplastic entity. And another important clue, sometimes seen in these cases of nephrogenic adenoma, is the presence of cells with a slightly signaturing morphology, which is important diagnostic clue, can be sometimes mistaken as a signaturing cell of a acinar adenocarcinoma. Now, immunohistochemistry has got some role to play. Always remember that AMACR will be expressed within these glands in the case of nephrogenic adenoma. So don't depend on AMACR to call it prostatic adenocarcinoma always, because this particular entity expresses AMACR. But if you do a triple marker, that is the pin-4 cocktail, you will see that those glands which are expressing AMACR in the form of red cytoplasmic granularity are also expressing the basal cell markers. And if you want to go into more specific markers, you could utilize markers like PAX8, which is more often routinely available. And if you have PAX2, you could also utilize PAX2 in order to reach a conclusion that yes, this is a nephrogenic adenoma, which characteristically expresses those markers. This range of glandular pathologies, that is atrophy, is a very important thing to consider when it comes to the pseudo-neoplastic entities. So there are multiple types of atrophy. You have got simple lobular atrophy, you have got cystic atrophy, you have got partial acinar atrophy, and you have got post-atrophic hyperplasia. Out of this, the simple sclerotic atrophy, the post-atrophic hyperplasia, and especially the partial acinar atrophy are important mimics of prostatic acinar carcinoma. Now, this is a simple lobular atrophy wherein you see that the glands, which are usually complex and large with the acinar cells showing abundant vacuolated cytoplasm and being thrown into papillary infoldings, that is completely gone. Rather, it is replaced by a lobulated collection of small glands wherein the cells which are lining the glandular lumen have got very scanty cytoplasm, resulting in an atrophic appearance. Now, however, given the lobulated appearance of this particular group of acini, you know that it's not going to be a neoplastic entity. The problem arises if these glands are kind of haphazardly dispersed within a stroma which is fibrocellular. So in that kind of sclerotic atrophy, you might sometimes give a false positive diagnosis of adenocarcinoma. Now, again, the utilization of the high molecular weight keratins and P63 in order to pick up the basal cell layer is very important in the case of acinar atrophy. And as you see in this particular case with high molecular weight keratins, as well as with the nuclear P63, you see that there is a preservation of the P63 in quite a good number of the cells of this basal cell layer, and also that high molecular weight keratin is picking up quite a good number of these basal cells. So this gland is obviously not a malignant one. Sclerotic atrophy, as I've said, especially on a needle biopsy, might create an issue because you can have an atrophic pattern prostatic acinar carcinoma, which could be an important differential diagnostic mimic. And sometimes in a sclerotic atrophy, you might also see that a few of these glands have got a bit of micronucleoli, which can further increase the diagnostic confusion. This image towards the left is actually a cystic atrophy, which should not create much of an issue. You have got these large dilated acini, which are lined by pretty much flattened atrophic looking cells, but you know that it's a benign one. The entity towards the right, however, is the one which is a very, very important diagnostic mimic for prostatic acinar carcinoma, wherein the cells look slightly rigid, slightly angulated, and slightly infiltrative with some amount of cytoplasm within this prostatic acini, as a result of which it gives the impression of a prostatic acinar carcinoma. So an important thing about these partial atrophic lesions is that they do not have the overall very scanty cytoplasm containing look that you see in the case of a simple atrophy. And because of this morphology and because of the fact that these glands are sometimes rounded to angulated and slightly atypical infiltrative looking, you have an important differential diagnosis, which is a prostatic acinar carcinoma. And as we shall see subsequently, even your pin-4 cocktails and your basal cell markers might not be able to reach a simple diagnostic conclusion that it's either a acinar carcinoma or a partial atrophy, and you might have to give it out as a diagnosis of ASAP. So as you see, these are these rounded to slightly angulated looking, suspicious looking glands where the cells, although they are looking smaller and slightly atrophic compared to the benign glands, they still have some healthy amount of cytoplasm, which is especially more prominent towards the lateral aspect of these cells compared to the apex. So that's an important clue. And compare this to the image on the right, which is basically a simple atrophy wherein the cells have no cytoplasm at all. So the image on the right is a simple atrophic gland, which is a pretty easy diagnosis to make, while the image on the left is a partial acinar atrophy, which is an important differential diagnostic issue with a prostatic acinar carcinoma. As you can see over here in the image on the left, you have this normal benign prostatic acini towards the bottom, but these particular glands, 1, 2, 3, 4, 5, 6, 7, this might create a diagnostic issue with the prostatic acinar carcinoma. Adding to this confusion is the fact that the basal cell layer is often not well appreciable within these glands, and you have a bit of prominent nucleoli sometimes, which, although not the macronucleolus kind of a look, are called micronucleoli. So this further increases the diagnostic confusion. As you see, these are the partially atrophic glands, and over here towards the right, we see that P63 has been done, and appreciate the fact that although a good number of the glands show at least partial expression of P63 showing that they're benign, there are quite some glands wherein you don't have this particular marker expressed at all. And because of the lack of this particular marker, within a few of these glands, you could still harbor the suspicion of a prostatic acinar carcinoma. Again, this is another case of partial atrophy. And over here, in this case, a cocktail marker has been utilized, which picks up both high molecular weight keratin and P63. And as you can see, there is absolutely no expression of those markers within these prostatic glands. And of course, in such a cases, it would be much more prudent to sign this out as a case of ASAP or an atypical small acinar proliferation rather than call it a partial atrophy. This is another case of partial atrophy where the PIN4 cocktail has been used, and as you can see, there's a bit of a striking morphology to these glands. Although a few of these glands express the basal cell markers, which are picked up in brown, a few of these glands do not, and rather those glands which are not expressing the basal cell markers are showing the cytoplasmic red granularity of MKR expression. However, you have to go back to the morphology on histology and see that those glands which are usually which are expressing MKR and not the basal cell markers do not look so threatening on a H&E slide. So this is how many of the cases of this partial atrophy will turn out. A few of these glands will not show expression of the basal markers and rather show expression of MKR, giving rise to false positive diagnosis. This is another important thing that needs to be kept in mind when assessing prostatic pathologies, especially on true cut biopsies. Never form your initial impression based on the IHC images, whatever kind of a picture your PIN4 cocktail might throw up. Always go to the histological image first. Try to have a kind of a graded impression as to whether it's a malignancy or whether it's a neoplasia or whether it's a pseudo-neoplastic entity or whether it's just a query a sub kind of a gland, and then go ahead and analyze your markers. This is another case of partial acinar atrophy where you see that the P63 and HMWCK cocktail has been utilized. Although a few of these glands have picked up at least patchy positivity for these basal cell markers, there are some glands which are not expressing any of this. So that's an important diagnostic pitfall as far as IHC in the case of partial atrophy is concerned. This particular slide highlights the same issue. Another case of partial atrophy. Over here, again, the glands are those of partial atrophy. However, I appreciate the fact that a few of these cells are showing micronucleoli, which can further increase the diagnostic confusion with the prostatic acinar carcinoma. And again, with a high molecular weight keratin, only a few of these acini have picked up HMWK, while quite a few of these acini have not. Now, this entity known as the post-atrophic hyperplasia is actually another pathology within the spectrum of atrophy, wherein along with atrophy, you also have an increase in number of these atrophic glands. And usually these increased hyperplastic but atrophic looking glands are usually centered around a central large dilated acinus. Now that's an easy diagnosis to make when you get a TURP specimen, but in a needle biopsy, supposing the needle goes through an area which is not having that large dilated duct, then you will probably run into a problem and might give a mistaken diagnosis of a prostatic acinar carcinoma. Like, say, for example, in this case, in the image on the left, there are a few of these glands which appear as if they're haphazardly infiltrative, and you cannot really well appreciate the basal layer in some of these glands, but appreciate the fact that a few of these acini are again still dilated, and this could still turn out to be a case of a post-atrophic hyperplasia. But remember that pH is an important mimic for prostatic acinar carcinoma. Like in this particular case, there is a hyperplastic process happening, but the glands are atrophic. And if you look closely, you'll see that most of the glands, you are able to appreciate the basal cell layer. However, a few of these glands might not show that basal cell layer on H&E. You might have to take the help of immunohistochemistry in order to pick up the expression of the basal cell layer markers. However, even in such cases, sometimes there will be glands which will show patchy, almost complete absence of the basal cell markers, and that needs to be kept in mind. So for example, in this particular case, this is a focus of PAH, and you utilize the PIN4 cocktail in this particular case, and you see that some of these glands are showing a preserved positivity for the basal cell markers, which are marked out in brown, while quite a few of these glands do not. Rather, these glands show some amount of expression of AMACR, thus raising a false positive impression of a prostatic acinar carcinoma. Now, this is another important thing that always needs to be kept in mind by the PG when they're analyzing prostatic, especially true-cut biopsies of the prostate. For example, in quite a few of these prostatic carcinoma patients, they would have been put on either radiation therapy or anti-androgen treatment, and following which you will probably be given a repeat biopsy. And in such cases, you need to be aware of the fact that these treatment processes might itself bring some changes within the glands as well as the stroma, which could give rise to a false positive impression of a recurrent prostatic acinar carcinoma. Now look at this image on the left. Now this is a case of a radiation treated case of prostatic acinar carcinoma. As you can see, the number of the acini are very, very reduced. You have a stromal predominance and the stroma appears sclerotic. There's an important change which is brought about in the prostate by radiotherapy. And at the same time, whichever glands you are seeing, you appreciate the fact that these cells look very basaloid. They do not have much cytoplasm to them, which is another important change which is brought about in the prostate by radiotherapy. The glands become shrunken and they have atrophic kind of a morphology. And within this atrophic gland, it might be sometimes difficult to discern the basal cell layer. A few important things need to be kept in mind. Usually these cells have got a bit of a smudgy, almost degenerated looking nuclear chromatin, and you also get vacuolation within the cytoplasm as well as the nucleus, which are important diagnostic clues as far as radiation induced changes in the prostate are concerned. Now this is a case of androgen deprivation therapy. The first case is a case of benign prostatic hyperplasia, wherein you see that those large glands with the complex luminal infoldings are gone. Rather, they're kind of replaced by smaller prostatic acini with a very atrophic kind of a morphology. So that same thing of atrophy can also be seen in the case of androgen deprivation therapy related prostatic tissue. And you see that there is an overexpression of the prostatic stromal element in this case. In both the cases of both anti-androgen treatment and radiation treatment, if you have an issue with the glands and if you have the suspicion that this could be a recurrent adenocarcinoma, always take help of P63 or HMWK, and you can see that this particular layer of hyperplastic basal cells will be very easily picked up with those markers. So that's an important thing to keep in mind. Now we move on to the prostatic intraepithelial neoplasia. This is just a kind of a stepping stone for the prostatic glands to step into the realm of prostatic acinar carcinoma. We shall be talking about it in a very short time, and we will not spend much time with this particular entity. Just keep in mind that this is a range of preneoplasias wherein the prostatic glands accumulate some amount of molecular genetic abnormalities in the form of the promoter hypermethylation of the GSTP1 along with the ERG gene rearrangements, which give rise to the prostatic intraepithelial neoplasia. You could talk about it as a dysplasia within the prostatic glands. And over a period of time, with the loss of the tumor suppressors like P27 or P10, and finally, along with the amplification of androgen receptors, you have a progression of the PIN to a prostatic carcinoma, which is initially localized and then becomes metastatic. So how do you differentiate these prostatic intraepithelial neoplastic glands from the normal prostatic acini? Always remember, in the case of the prostate, there are two types of prostatic intraepithelial neoplasia. There is the low grade and the high grade ones. Keep in mind that we do not talk about the low grade prostatic intraepithelial neoplasias. It's only the high grade prostatic intraepithelial neoplasias that I'll be talking about in this particular chapter. So the first and the primary thing that you look into the cell, into the acinar cell, in order to say that it's a case of high-grade prostatic intraepithelial neoplasia is the prominence of the nucleolus. This kind of very prominent, almost cherry red macronucleolus will not be seen in the case of a benign prostatic acinar cell. And Because it's an intraepithelial neoplasia, you will see that the outer layer of basal cells, which is seen in the case of the normal prostate, is also preserved at least partially within these glands, which are involved by a prostatic intraepithelial neoplasia. But again, whenever you see high-grade prostatic intraepithelial neoplasia, look around into the adjacent stroma, you might see an invasive adenocarcinoma element also present along with also present along with this particular pathology. Now, there are 4 architectural patterns of prostatic intraepithelial neoplasia. Sometimes you will have a bit of a tufting, that is a bit of a luminal undulation of these glands which are showing the pin. Sometimes you will have a much more florid filiform kind of finger-like projections, which is known as the micropapillary pattern. The first one is the tufted pattern. The second is the micropapillary pattern. Sometimes you will have a joining of these tufts and the micropapillae giving rise to a punched out cribriform kind of a pattern, and sometimes you might just have a layer of 1 or 2 cells which are showing this pin-like prominence of the nucleolus, which is known as a flat pattern. So in these images, you get to see the luminal undulations of the micropapillary pattern along with the tufting, along with some amount of tufting as well. And over here, you are seeing a mostly micropapillary, but also appreciate the fact that there are a few luminal undulations like the tufting pattern also within these glands. Keep in mind that you are not really supposed to focus on the nitty-gritty of the micropapillary architecture versus the tufting versus cribriform. It is just to help you identify the fact that you are probably dealing with a gland which is a preneoplastic one. In this image on the right, you have a cribriform pattern which is present within the AGPIN glands. Again, here you have a usually you have mostly a micropapillary kind of a pattern, whereas in the image on the right, you have a combined micropapillary as well as a cribriform growth pattern within the AGPIN glands. In this image on the left, you have a mostly cribriform pattern, while the one on the right shows a tufted kind of a pattern with the luminal undulations. But you appreciate the fact that the acinar cells are all showing very prominent macronucleolus, which is the most important cytological diagnostic feature to call a prostatic acini as a AGPIN acini. So these are the important things that you need to keep in mind. You need to appreciate the fact that the cells are atypical looking with some amount of nuclear overlap, coarse chromatin, and most importantly, the prominent nucleolus. Because it's an intraepithelial neoplasia, you will have a preserved layer of basal cells outside. There should not be an absence of the basal cell layer, because if there is a complete absence of the basal cell layer, you are dealing with a prostatic acinar carcinoma and not a prostatic intraepithelial neoplasias. What are the elements to report? You will have to look for suspicious glands adjacent to the focus of the prostatic intraepithelial neoplasia in order to rule out an invasion. You will have to count the number of the biopsy cores which are involved by the high-grade prostatic intraepithelial neoplasia. You'll have to even count out the number of the foci of those AGPIN that you are seeing in a biopsy, and talk about any atypical small SNR proliferations which you think might be suspicious for cancer in this particular context. This is just a revision of the markers that we had talked about till now. They have been covered in detail in my first chapter. I'll be talking mostly about the basal cell markers. So the basal cell markers that we have talked about are the high molecular weight keratins, which are expressed in the basal cells exclusively. And the keratin, which is most often utilized immunohistochemically, is the 34 beta E12 clone, which picks up anticytokeratin high molecular weight keratins 1, 5, 10, and 14. Remember that with a few of the pseudo-neoplastic entities, even high molecular weight keratin might not show expression within the non-neoplastic glands. So it is not an absolutely foolproof thing to call something benign vis-a-vis malignant. Another marker for these basal cells is the nuclear marker, that is the anti-P63, with the same range of diagnostic pitfalls that you see in the case of high molecular weight keratins. In order to increase the sensitivity of both P63 and as well as HMWK, you have cocktail. You have 2 antibody cocktail markers, like which can pick up both the nuclear expression of P63 along with cytoplasmic expression of high molecular weight keratin, and these are obviously much more sensitive than individual markers of HMWK and P63. And as I said, the granddaddy of them all is the PIN4 cocktail, or the triple marker, wherein you have a combination of various antibody clones which can pick up high molecular weight keratins as well as P63 within the basal cells. And if there is any expression of AMACR within the neoplastic cells, that will be picked up. The basal cell markers are usually labeled with the horseradish peroxidase along with Dept chromogen. So if there is any basal cell, they'll be picked up in brown. while MACR is labeled with alkaline phosphatase and fast red. So if there is any MACR expression, it will be picked up in red. Like in this particular case, you see the benign glands wherein there is a basal marker positivity and there is no expression of MACR, while the neoplastic glands of infiltrating acinar carcinoma are showing the reverse pattern, wherein you have a red MACR expression but no expression of the basal cell markers. Now, in the case of a high-grade prostatic intraepithelial neoplasia, what is the thing that you expect? You expect the basal cell layers to be positive, because if they're totally absent, then it's a prostatic acinar carcinoma. Remember that the basal cells in the case of high-grade prostatic intraepithelial neoplasia need not be uniformly present throughout around the gland. They could be patchy and still it would classify as a HGPIN gland. Like in these particular cases, you see that these high-grade prostatic intraepithelial neoplastic glands, you can make them out by the very prominent nucleolus within the cells, are still showing some amount of patchy expression of the high molecular weight keratin. And that is enough to call it a non-adenocarcinomatous gland. So this is just a HGPIN. Again, over here, you see that most of these glands are at least showing some amount of expression of the basal cell markers. That is enough to say that this gland is not a carcinoma. Okay, so in this particular case, again, you see that there is an expression of high molecular weight keratin as well as P63 in A and B. And there is a little bit of expression of MACR also within the glands of the HGPIN, but towards the left, lower left of the image, you see that the glands are the acinar carcinoma glands, which are lacking expression of both HMWK as well as P63, and rather they are expressing MACR with a much more intense intensity. In the case of a pin-4 cocktail, in the case of HGPIN gland, you expect some of the cells to show variable amounts of MACR positivity, while there is still a retained patchy positivity of the basal cell markers, which are picked up by the P63 and the high molecular weight keratin clones. In this particular case, again, you see that some of these glands at least are showing some amount of expression of the basal cell markers, and there is a partial expression of MACR within the glands of HGPIN. Now, the next issue is if there is an HGPIN, is there an invasive acinar carcinoma? So if there is an invasive acinar carcinoma, look around in the focus of HGPIN, you will sometimes get to see these very small, haphazardly infiltrative, occasional glands, which are lacking the basal cell layer, but which have got the prominent nucleoli. This could be invasive glands of prostatic acinar carcinoma. However, if there are only a few of these glands in number, and you cannot really exclude the fact whether it's a tangentially sectioned HGPIN gland, it's better to give a diagnosis of ASA on those particular glands and not call it straight away an acinar adenocarcinoma. So, of course, if you utilize a high molecular weight keratin, you will see that those neoplastic glands, which are actually the invasive carcinoma, absolutely lack the expression of these basal cell markers, while the HGPIN glands show some amount of patchy retention of the basal cells. So in the case of adenocarcinoma prostate, I shall be talking about adenocarcinoma acinar in much more detail in my coming classes, but in this particular lecture, we shall just talk about a few of the basic hallmarks that you see in the case of a adenocarcinoma glands. The glands will absolutely lack the basal cell layer. The cells will show prominent cherry red macronucleolus in most of the cases. And if you do a pin-4 cocktail, you will say that the glands absolutely lack the expression of the basal cell markers, unlike the normal glands, while they show much more diffuse positivity for MACR expression, which is picked up in red. So when it comes to approaching the prostatic needle biopsy in diagnosing adenocarcinoma, first focus on those areas of the slides which are showing the benign glands. Keep a snapshot of those glands in your mind. Then look out at the areas of the core where the glands appear slightly different looking. Maybe they could be haphazardly infiltrative looking, or they could have less amount of cytoplasm. And then go into a higher power view of those glands and see whether those glands differ cytologically from those glands which are the benign glands which you are using as a reference. Like in this particular case, first move into the glands which are basically normal. You see them all over, but at the same time appreciate the fact that there is this small, slightly haphazardly infiltrative angulated glands wherein you do not see the basal cell layer. So these are obviously suspicious glands. You have to count them in number. So usually the rule is that if there is less than two dozens of these glands, you will usually give a guarded diagnosis and call them as ASAP. Again, you have these infiltrative atypical looking glands which are seen to infiltrate between the normal prostatic acini. And sometimes these glands, rather than being haphazard, they could be crowded, and this could actually be mistaken for an adenosis and vice versa. So that's another important thing to keep in mind. Another important clue is the presence of these glands in a linear fashion, almost a straight line fashion, running from one edge of the biopsy core to another. That usually is a clue that this could be a prostatic acinar carcinoma. IHC would be warranted in such cases. Sometimes you will not get proper gland at all, rather the cells will be haphazardly infiltrative, forming this kind of narrow trabeculae, which is obviously a pattern 5 prostatic acinar carcinoma, or they could form sheets without any glandular architecture, which is again a pattern 5, Gleason pattern 5 prostatic acinar carcinoma. Again, like I said, nuclear atypia, appreciate the fact that those acinar cells show very prominent nucleoli, which is an important diagnostic clue to call it a acinar carcinoma. And also the fact that there is no basal layer expression within those glands. And these are some of the soft clues which you see within those glands of acinar carcinoma. Sometimes they tend to form these small round balls within the lumen, wherein you can appreciate those small glandular spaces giving rise to a glomeruloid appearance. So this glomerulations is another important soft clue for diagnosing a prostatic acinar carcinoma. Sometimes the extravasated mucin, which is ruptured out of the glands, could become collagenized, giving rise to a structure known as collagenous micronodules. So those are again soft clues. And the absence of the basal cells is one of the most important thing which helps to identify a prostatic acinar carcinoma gland. But if you have followed this particular discussion till now, you will know that the glands that you are seeing on the left, that is, say, for example, this cluster of glands, a partial acinar atrophy could still be an important differential diagnostic issue, and you will have to take help of immunostain. Like, for example, in this case, basal cell marker nuclear P63 is seen to be retained in the normal glands, while the malignant infiltrative glands are showing a loss of expression of P63. With a triple cocktail, you see that the preserved benign prostatic acini are showing the brown positivity for the HMWK along with P63, while they are not showing MKR expression, while the neoplastic glands of acinar carcinoma are showing the reverse pattern. They do not show basal cell marker expression and rather show expression of MKR. Some other soft clues are the presence of blue mucin, crystalloids, etc. within those glands, which could further raise a suspicion. Coming to the last entity of this discussion, as I have already said, ASAP, or atypical small acinar proliferation, is basically a constellation of findings within suspicious glands where you are not confident enough to give a straight out diagnosis of a prostatic acinar carcinoma. You also have the diagnostic dilemma of maybe issues like especially a prostatic atrophy of the partial type, or maybe sometimes an issue with a post-atrophic hyperplasia. In such cases, you would probably choose to use the more guarded terminology called atypical small acinar proliferation. But remember that that is not a single entity. Any case where you have a diagnostic dilemma of an adenocarcinoma versus a pseudo-neoplastic mimic, even after immunohistochemistry, would go out with this particular level. Also remember an important thing, it's probably a good idea to avoid utilizing this term in each and every prostatic biopsy that you come across. You have to be very, very diligent, because otherwise your urologist might lose faith in you. So that's a diagnosis which should be given out after a long deliberation, and probably in a group which has multiple pathologists seeing a single case, where you will probably need to have a vote of consensus. So in this particular case, as you see, these glands within this particular focus have raised the issue of a partial atrophy versus a cancer. And you use immunohistochemistry, you have used the PIN4 cocktail in this particular case. You are seeing that the normal prostatic, in this particular case, you haven't used the PIN4 cocktail, you have used the 34 beta E12, that is the HMWK. So here the HMWK is basically labeled to alkaline phosphatase with fast red, which is why it has picked up the red positivity. So you see that the normal prostatic glands are showing expression of high molecular weight keratins, while those slightly suspicious looking glands are not showing expression of HMWK. However, given the fact that there are only a few of them, that is, there is a quantitative deficiency, you would still probably call it out as ASAP rather than call it a acinar adenocarcinoma straight away. So the main issue with the diagnosis of ASAP is that some of your colleagues might feel that you are dealing with an adenocarcinoma and call it a minimal adenocarcinoma, and you, being the more hesitant one and the one who's probably a bit more guarded, would still choose to go with the diagnosis of ASAP. that would basically convey to the clinician that you still have a suspicion of an acinar adenocarcinoma in mind, but you cannot totally exclude the pseudo-neoplastic mimics, and that a close follow-up of this patient along with serial PSA monitorings and again repeat true-cut biopsies is probably warranted. So in this particular case, which I have taken from a textbook, you see that within the background of normal prostatic glands, you have these 3 glands which raise a suspicion because of the absence of the basal cell there, and the cells look slightly atypical with slightly prominent nucleoli. So you utilize the markers. So, and on utilizing markers, like especially the PIN4 marker, you see that these glands are expressing MKR, but at the same time, they're showing lack of expression of HMWK and P63. So that fits in with the definition of a prostatic acinar carcinoma. But given the fact that the number of these glands are very few, you will not call it a prostatic acinar adenocarcinoma. You will give a diagnosis of an atypical small acinar proliferation. The same issue with this particular field, wherein you see that these glands which are marked out in arrows, we can actually count them out, like say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So these glands give the suspicion that is as if they are acinar carcinoma glands. You cannot appreciate the basal cell layer well. The cells look slightly atypical. At a higher power, they will have prominent nucleoli in some of them. And if you utilize the PIN4 cocktail, you will see that they are expressing MKR, but they are not expressing basal cell markers, unlike the normal basal glands. Unlike the normal banal glands, which are showing the expression, the exact opposite pattern of expression. But given the fact that there are only 10 or 12 in number, you will still probably not sign it out as a straightforward acinar carcinoma. You will call it an ASAP. So there are a few histological rules which are given in the biopsy textbooks as far as making the diagnosis of ASAP is considered. First of all, the quantitative aspect is very important. So if you have usually less than 20-24 glands, and if the focus size, if you do a morphometry, is less than 0.4 mm diameter, you will not call it a acinar carcinoma. You will call it an ASAP. And if there are some factors which are hampering your interpretation of the slide, like say, for example, there could be a tissue processing artifact or a thick section or a poorly fixed specimen, you will not call it a acinar carcinoma. That is common sense. If you see atypical glands at the tip or the edge of a biopsy core, refrain from making a diagnosis of a pseudo-neoplastic lesion. There could be an unsampled adenocarcinoma which is lying outside the zone. So you'll give a diagnosis of ASAP again. If you see an atypical gland, which can be seen within both a non-neoplastic as well as a neoplastic one, for example, say an atrophic pattern gland or a haphazardly infiltrative pattern of these glands, or an inflammatory biopsy where you are getting some amount of atypia, which is probably more than the inflammatory atypia, you will again give a diagnosis of ASAP. And if there is, even after doing IHC, you might, as I have already shown, might not be able to give out a diagnosis of prostatic acinar carcinoma because, say, for example, you could have a benign gland which is expressing MKR, or you could have a benign looking gland which is not showing expression of the basal cell markers, and you will still give a diagnosis of a ASAP in such cases. So basically, remember that ASAP is basically a diagnosis of exclusion after you have deliberated over the range of entities which can be seen, both neoplastic as well as pseudo-neoplastic, probably along with 2 or 3 other pathologists. That is actually the best way to approach such cases. And then after taking a vote of consensus, you have decided that this prostatic biopsy is neither is it unequivocally malignant, nor can you totally exclude a malignancy. So you would end up giving a diagnosis of an ASAP. Thank you very much.